So, good morning. It's my pleasure to be here with the Dr. Alexander Benz today to speak about his work titled Outcomes of Patients with Atrial Fibrillation and Ischemic Stroke despite receiving oral anticoagulation. So, Dr. Benz, first of all, congratulations for your study. I think it's really very interesting.
Thank you. Please call me Alex.
Okay, so thank you, Alex. Really, you are touching one problem of our society, which is the atrial fibrillation with a very high rate. And despite giving these patients the theoretically best treatment, you have shown that they are at very high risk of recurrence. Can you give us your opinion on this?
Of course. So patients with atrial fibrillation who suffer an ischemic stroke despite receiving best medical treatment with oral anticoagulation are at very high risk of adverse events. But the prognosis of these patients is really not well understood. So in this study, we aim to estimate the incidence of recurrent ischemic stroke and death in patients with AF who suffer an ischemic stroke despite oral anticoagulation therapy.
Okay, and I was wondering if did you find any difference between patients with NOAC and patients with anti-vitamin K?
That's a great question, and maybe I'll summarize what we did and how we did the analysis, and then I'll get back to that question. So to answer our primary research question, we used the Combine AF dataset, which is an individual patient database of all the patients enrolled in the pivotal trials of DOAC therapy in atrial fibrillation. The RELY trial, Averroes, Rocket, Aristotle, and Engage AF TIMI-48. And we included all patients with first post-randomization ischemic stroke while being on an oral anticoagulant, as you say, a DOAC or a vitamin K antagonist. We excluded those with permanent discontinuation of study drug prior to the first event. And we also excluded those few patients who were randomized to receive aspirin in Averroes. Mm-hmm. So in total, we ended up with 1,163 patients with AF were being treated with oral anticoagulation therapy who had a first post-randomization ischemic stroke. And then we continued to follow these patients with the index event marking day 0. Mm-hmm. Maybe I'll at this point summarize the main finding. At 1 year, the curative incidence of recurrent ischemic stroke was as high as 7%. Which I think is much higher than what we usually see in patients or in a more general AF population where anticoagulation is being used for primary prevention of stroke. The second main finding was that mortality following a first post-randomization ischemic stroke while being treated with an oral anticoagulant was also very high, at around 12% at 3 months and as high as 18% at 1 year.
Yeah, it's really amazing. This is very ill patients, I guess. So in your conclusions, you said that this is a problem that should be addressed by clinical trials. What do you think we should do with this kind of patients?
Yeah, you're raising a very important point. I mean, we, as you know, I'm a cardiologist. I guess you're a stroke neurologist, and mm-hmm. we don't really have good options for these patients. And I believe evidence for therapies that, in addition to best medical care, is lacking. So what we need to realize is that despite best treatment, the event rates are very high. And as you say, I believe randomized trials should evaluate strategies aimed at improving outcomes. I mean, what comes to mind, of course, is intensification of the antithrombotics, although many trials in a more general AF population fail to show a reduction in stroke with the addition of an antiplatelet. And of course, there's also increase in bleeding with that. So that's something to keep in mind, especially when patients have already suffered an ischemic stroke. Another thing or another strategy that comes to mind is mechanical therapy by means of left atrial appendage closure. But I'm not sure we can, extrapolate the evidence that's there to our particular high-risk group that we studied. So I believe, studies that evaluate mechanical therapy in addition to oral anticoagulation is probably something that we can think about.
Okay, yeah, I agree. This is an option we should consider. But maybe first we should try to identify these high-risk patients. Do you think we have enough with chest VASc, or we should go a bit further with this?
It's a great point. I mean, in our study that included, more than 1,100 patients, more than a third of these patients had already suffered a prior stroke before enrollment in the trials. So the first post-randomization ischemic stroke in these patients was actually at least their second one. So of course, prior ischemia or cerebral ischemia is one of the strongest risk factors also in this setting. The mean chest VASc score of these patients was a little more than 4. But I believe, novel approaches to risk stratification are probably needed, and we've seen some encouraging results using biomarkers. The ABC scores come to mind that combine age, cardiac biomarkers, and clinical history of stroke. But these scores have not been validated in this particular setting.
So congratulations again. I think you are opening a line for new studies and to improve to try to improve the prognosis of this kind of patients. So thank you very much.
Thank you. It was a pleasure.